then welcome to come and see it on the screen over here. All right. Okay. So the last time we covered in X-rays, shoulders, shoulder dislocations, and things like that. Today we're going to cover some fun stuff, things that you won't normally see. So if you don't get it, I don't blame you, but if you do get it, it's a lot of fun. All right. So let's try. So here we have a shoulder. Okay. I want you to find the fracture. There is a fracture. Okay. I think you guys can move some chairs onto this side. God, I hope nobody has COVID. I'm in so much of trouble. Yeah, you can bring some chairs from outside if you want. There should be some. Sure. Okay. Okay. Yeah. So, like I was saying, can you find the fracture? And if you can't find the fracture, that's fine. If you want to come and see it on this screen, come and see it on this screen. Okay, hopefully that should be a bit better. Okay, so your patient is in severe pain. And I picked this one because it's quite a difficult one. All right, this is where I have fun, watching you all sweat, trying to pick out fractures. All right, so in any case, even before your patient goes for their X-ray, they are having severe pain on abduction and adduction. So what's abduction and adduction of the shoulder? Ab and add, all right? So when they're doing that and they're doing that, it's extremely painful, right? And they have quite significant swelling, which you can actually see around you, all right? So, I mean, even if you can't pick out you can't pick out the fracture, but can you see the swelling over here? All right, that's a lot of significant soft tissue swelling. All right, so what happens is with all of us, we tend to pick out what we know. All right, so all of us know the humerus. So we tend to look at the humerus. I hope you guys can see that one, all right? And if you don't see the fracture after that, don't stress. You can come and have a look at it on here, all right? So let's abduct our arms. Not all together, you will hit somebody, all right? But as you abduct your arm, which bones are involved? Okay, humerus number one, all right. Number two, hey. Scapula, right? Scapula, very good. Any other one? Collarbone, right? Clavicle, all right. And the joints that they all form, all right? So the ACJ and things like that, all right? So in other words, you've only got basically three bones to concentrate on. It's either the humerus, it's the clavicle, the clavicle or the scapula. And does anything look strange? What? Yeah, there's like, no, that means nothing. Come show me here. That's like being on Who Wants to Be a Millionaire. Do you know the capital of Mongolia? Yes. Give me my money. Come show it to me. Come. Come move the mouse to where you see the fracture. Yeah, I know. All right.
Well, it should be here just next to the end.
That's not a bad guess, but it's not, all right? That's just your normal acromioclavicular joint, okay? But it's not a bad guess, all right? Okay, now I know it's gonna be, I want you guys to come and see it on the screen, all right? So come around, I'll show it to all of you, okay? Right. Right, at least one by one, all right? So what I want you guys to do is go and have a look at a normal scapula, all right? So a normal scapula makes an X. Sorry. A normal scapula makes an X like that. Can you see this one? Look at that area now. Does that look normal to you? No, not at all. Can you see the fractures? All right, so your entire scapula is fractured over there, all right? So scapular fractures, while uncommon, do occur, all right? Now, this was a particularly difficult one, all right? Now, even though you guys didn't pick it out, it's not the end of the world, all right? The reason why I wanted to show you all this is because sometimes it's very difficult to pick out rare fractures, odd fractures, difficult fractures, things like that. So you have to look at the patient themselves. So even if you didn't pick out the fracture, just the fact that you know that there's significant soft tissue swelling, a patient can't abduct and adduct their hand, at least it means that you will go and ask for help. But it also means the next time that you see a scapula, which we'll look at some scapulars just now, you'll see that they actually make the scapular X. All right. So think X-Force, Deadpool. All right. So they don't have that. Okay. I would have said X-Men, but you're all a bit young for X-Men. Anyway. I mean, not young, but I mean, it came out like when I was I used to go to movies. I've forgotten what that's like. Okay. All right. So this is more of a common X. Can you see that X there? All right. Can you see that X? All right. Now let's compare it to the previous one that we had. All right. And now look at that X. Can you see it doesn't make an X per se? All right. So the scapular X is quite a good landmark to actually have you look at what's going on in the scapula. All right. Now here we're talking about isolated scapular fractures. All right. Now these are very hard to see on plain X-ray. For example, there's just a bit of the top of the scapula that's come out of here that's fractured, and this is the acromion. All right, that's fractured away from the rest of the scapula as well. All right, so they are extremely, extremely difficult to see on X-ray. All right, they are fun when you get them. You feel very nice, you feel very clever, and you go and you show it to everybody that you're working with. Okay, like look at that, look at that, look at the X, look at the X, and they're like, oh, okay, it's 3 a.m. Shut up. Yeah, okay. So CT is often the best way to look at it, all right? Now, when do you suspect these things, all right? Suspected if there's significant trauma. It takes a heck of a lot of trauma to fracture a scapula, all right? It's not an easy thing to fracture, okay? The second thing is it has pain the significant swelling as well, which you can see even here, all right? So the swelling is not isolated to the shoulder. Can you see the swelling along what would be the trapezius, all right? And the latissimus dorsi, all right? So this person suddenly looks like a bodybuilder on the side of the injury. Okay. And then they have pain on the form movements, abduction and adduction, right, which is quite easy, all right? And then extension and flexion, all right? So you think of bench pressing at the gym, all right? So that's extension and that's flexion, all right? So the scapula is the one that actually keeps your shoulder in place. When you go to the gym, you can see, you know exactly what I'm talking about, isn't it? All right. So your scapula is the one that stabilizes the entire shoulder during those movements. Okay. So that's how you make it out. All right. So here you can even see a little what we would call a acromioclavicular dissociation. Okay. Where it's come a little bit apart. All right. Now, the other thing is, the reason why isolated scapular fractures are so rare is because it's very hard to fracture this on its own without fracturing something else, if you get what I mean. So your scapula is kind of hidden in the back over here, all right, your shoulder blade. So it kind of has to be a direct trauma that's kind of, aimed at the scapula for it to fracture on its own. But most people don't, how do I explain it? Try and get hit particularly on the scapula. So you've got your humerus around there, you've got your ribs, you've got your clavicle, you've got a whole lot of things that are around. So it's very rare to find them in isolation. Okay. All right. So let's try another one. All right. Now, what I want you to do is not just look for X-rays. All right. But okay, that might be a bit difficult to see on there. Trying to see if I can. I know there's no way I'll be able to make it better. All right. So you guys are more than welcome to come and look at it here if you want. All right. Okay. Let's start in. Come. You can come around. And then let's have a look at it and see. Those who are on Zoom will be able to see it better. Let me move it a little bit forward just so that everybody can see. All right. So let's have a look. All right. So first of all, which side is the swelling on? Even if you're not worried about bones, which side is the swelling on? Right or left? Soft tissue swelling. Very good, left. All right. So you can see there's a whole lot of swelling. So at least it tells you which side to concentrate on. Now, of course, we are at a disadvantage because we haven't had a history. Normally you get a history before you just do an X-ray. All right. Can you see it there? Can you see it? All right. All right. So we know that the problem is on this side. So let's have a good look at this X-ray and tell me what problems you pick up. What can you see? There's a lot to see. Yeah, so pick one. Very good. All right, so let's have a look at the clavicle. All right, so once we have a look at the clavicle, we can see the fracture here. All right, so it's in the middle third. So here you can see a normal clavicle on that side. So let's follow this clavicle and see it there. And suddenly it goes off this way, all right? And if you follow it there, you can see the clavicles attached there, and you can see the clavicles not attached there. All right, very good. So he's got a clavicle fracture. So we put him on collar and cuff, go home. No, all right, so what else is going on? Sorry, yeah, very good. Okay, wait, I heard lungs, heart, which one shall we do first? Okay, what's happening with the lungs? Why do you say it's punctured? And what is the term that we use? Pneumothorax, very good. We don't say punctured lung. Okay. No, it's fine. You can say punctured lung, but then we'll put you in the waiting room with the rest of the patients. Okay. So why do we suspect a pneumothorax? No, the injury doesn't mean that there's a pneumothorax. Actually, there's quite a few lung markings on this side. Okay, what's happening there? Is blunted, but is that a sign of a pneumothorax or a hemothorax? Very good. So there's a sign of a hemothorax. Okay. Anything else that we notice? On this side here. Actually, if you follow the lung markings, you can actually see them going out right to the edge. For example, if you follow this lung marking, can you see it going right out over there? Okay. The reason why it looks like that is simply because this side is so wide. Okay, so that's why it looks like that. All right, so far we've picked up a hemothorax, we've picked up a clavicle fracture. Why does this lung look so wide?
Could this be a fracture here?
Yes, that is. Any other ones you can pick up?
Here, I think 1, 2, 3.
That's the head of the humerus. Okay, yeah, you're right. It doesn't look right. So this is the head of the humerus. So is the fracture there or is the fracture here? Which one are you talking about? If you compare it to this side. Compare the two sides to one another. Which one looks strange? The head? The head or the glenoid? The glenoid, what looks strange about it? If you look at this one, it's attached to your scapula. If you look at this one, it's not attached to your scapula. So your entire glenoid cavity has moved out from your scapula. It's no longer attached to the scapula. All right. So the scapula makes up the glenoid cavity. So now there's currently a glenoid cavity that just boom, came out like that. All right. So the arm is still fine. Okay. But it's good. At least you spotted that it's out. Okay. And then we've spotted 1, 2, 3, 4, 5, 6, 7, 8, 9, maybe 10. All right. So what is this where the ribs have fractures on two ends? What do you call that? Flail chest. Very good. Okay. So that means that person is not perfusing that lung, or at least ventilating that lung. But the last question, why is this lung so wide? There could well be a pneumothorax here. I'm not denying it. It's just very difficult to see. And if it was there, it is a difficult one to see because you've got the scapula running over there as well. But why is this lung white? What could cause it to look white? Yeah, surgical emphysema, definitely. But surgical emphysema, yes, lack of oxygen, definitely. What do you call that? Well, let me just say the surgical emphysema, number one, you normally see streaking. All right, so you normally see air not just above the lung, but in the soft tissue as well. Now, when you say lack of oxygen, what do you mean, Doc? Okay, lung ischemia, hypoxia. No, you can't say hypoxia on the lung. What is happening to that lung? Is it collapsing? Is it atelectasis? All right, so atelectasis leads to that. Anything else leads to whitening of a lung? We know fluid, all right, but fluid tends to be more like a solid, all right? Sorry, I know that doesn't make sense, but you get what I mean, all right? What else can lead to this type of a picture? Infections, all right? But this patient did not develop an infection because they were having trauma. So what else can make it look like this? Is blood, all right? Diffuse blood throughout the lung, also known as a lung contusion, all right? If you look at this patient, you can actually see the ET tube is already in, all right? I don't think they've put the IC drain in yet, all right? So in this patient, are you going to go and have a smoke and come back in 10 minutes? How much of trauma do you think it took to do all of this? Quite a bit. From which side do you think the trauma came? From the front, from the side, from the back? Most likely from the side, right? So a huge amount of force got applied from that side. Such a huge amount of force that it was able to fracture the glenoid right off the scapula, fracture the ribs in about 11 places, fracture the clavicle, lead to a large amount of contusions. There is most probably a pneumothorax underneath here as well. I would suspect it's somewhere around there. And there's blood as well, all right? But it just goes to show you how much of damage can occur. And you've got to look carefully at it, all right? So it's not a clavicle fracture only, okay? So even though we may be concentrating on fractures, but look at everything, all right? So let's look at what we have. So we have contusion of the left lung, all right? Multiple rib fractures that we saw over here, all right? So you can see where the ribs have been fractured and pushed in, all right? Flail segments, all right? Suspected hemo, clavicle fracture, ACJ displacement. And then, like I say, when we compare the two glenoid cavities to one another, all right? So here's the normal glenoid. So the normal glenoid comes up here, and then there's the glenoid, capsule and cavity. And then when you follow it on this side, can see it's pushed completely out of place, all right? The humerus is still attached to it, but it's no longer attached to anything, all right? So like I say, and your glenoid is formed by a scapula, all right? So let's try some more. I don't know if you should be able to see this on the screen now. Shouldn't be too difficult, but if you're having any trouble, more than welcome. I missed that screen so much, that one that we had. You should ask them to give it back to us, but anyway. Okay, so don't worry, we're almost done. Today is not a very long one. So clavicle fractures, right? So there's three types of clavicle fractures, right? So there's three types: proximal, right? So when we say proximal, we mean closer to the center, right? So in other words, in the first third, all right? There's the middle third, which is there, and then of course in the distal third, which is there, all right? Proximal are the least common, all right? So in other words, very hard to just fracture the clavicle in this area. It does happen, but it's very difficult. And if that does happen, we've previously talked about sternoclavicular dissociation and dislocations, and the same thing applies. There's a lot of vessels and a lot of things that are running underneath here. And if you do have a fracture here, patient needs a CT because they need to look at how all those vessels are doing, and if there's any vascular injuries or thoracic injuries. And it's also very hard to crack a clavicle here without cracking a rib or things like that. The middle third, in other words, from about there till there. So the easiest way to figure it out, if you feel your clavicle, all right? If you feel your clavicle, where that bend is, all right, that's the middle third, okay? The flat piece here at the front, that's your proximal third, and the flat piece at the end is your distal third, okay? And then, like I said, the distal third, also you do get fractures over there, and those fractures sometimes are associated with ACJ dissociations, all right? So most of these are managed conservatively. In other words, you put the patient in a figure of 8 bandage, okay? So in other words, it just keeps their clavicle still, because that's all that you really need with any sort of fracture. You just need to immobilize it, and then it heals over a matter of weeks, but it's extremely painful. The question is, when should you be worried about any sort of clavicle fracture? And it applies to most fractures. When it's an open fracture, when there's severe skin tenting. So in other words, the clavicle has pushed up, hasn't necessarily pushed through the skin, but it's causing a lot of pressure on the skin above it, okay? Proximal fractures, all right? And when the fracture is comminuted, so in other words, multiple pieces, all right? And it's severely angulated or displaced and things like that, okay? So this is one that's just showing us a distal fracture with ACJ dislocation as well, all right? So clavicle fractures, you'll see more than enough, don't worry. All right, we almost finished. Today was not a long one, actually, because I want to go on leave tomorrow. So I didn't want to do too much. All right. So the humerus, all right, proximal fractures of the humerus. Okay, so it's a very common injury to have these fractures around the surgical neck and the head and things like that. It's a very common injury in elderly patients, all right? They tend to fall, they tend to land on their shoulders because they don't have good saving reflex, all right? So you and I, when we fall, we stick out our hand, but babies and the elderly just kind of flop, All right, so when they fall, they just fall. So then they fall directly onto their shoulders. All right. So the classification that's used is called the near classification. I don't know if that will come out in your exams, but I just put it there just in case. All right. And it's classified from 1 to 4, depending on the number of fragments and how it's attached to the glenoid. I think it's unlikely to come out in you guys' exams unless you're becoming orthopedic surgeon straight out of the gate. But just so that you'll know, that's what it's called. Right. So of course, you'd expect pain on movement. Very common is ecchymosis. Any idea what's ecchymosis? Bruising, right? Fancy way of saying bruising, all right? So ecchymosis is bruising and bleeding under the skin, all right? And then often what they tend to have is numbness and weakness of the arm as well, right? Because of the, what you might call it, nerve distribution around the radius, around the humerus. That's why you tend to get these numbness and weaknesses and things. What happened there? Things switch off. Shouldn't have. Down. There we go. Did it just get pissed off? Okay. Yeah, man. There's only one more slide to go, so I don't know why it's behaving that. Is it gone again? Yeah, maybe it's a power supply. All right, I'll try and show you guys this way then. Shut up. You're ready for this. Fine. All right. All right. So actually, this is the last slide, so not to worry. So this is just humeral shaft fractures. And yeah, I hope you guys can see. So they can be classified as, you can come and have a look. Okay, so they can be classified as spiral. Right? Now this applies to femurs as well, or any sort of long bone. So you can have a spiral fracture that kind of goes up like that. You can have oblique fractures, transverse fractures. You can have simple fractures, comminuted fractures, open fractures, closed fractures. It doesn't really have, I mean, these are just common words that are used in all fractures. Okay, you can have an open or a closed fracture. The main problem with this is that as you come more distally, there's a greater chance of radial nerve injury, right? And the other thing that's quite worrying around here is also your, what you might call a brachial artery, right? Because it tends to get stretched around this area. And you can have quite severe venous injuries as well, the cephalic and basilic veins. So those are also things that you need to worry about, okay? And in children, just be wary of possible child abuse. It's very hard for a child to fracture their humerus in the shaft, okay? In other words, when they fall, they tend to fall on their elbows, their hands, or on their clavicles. It takes a direct blow to actually fracture a child's hand. And when children do fracture because of falls, they tend to get what we call green stick, torus fractures, those types of things, buccal fractures. So it's very hard for them to get spiral fractures and oblique fractures. It does happen. It's not that it's impossible, but you just got to start thinking about it. All right. So these were just some. Now, the next time we do x-rays again, we've got some fun ones again. But I just wanted to show you all the scapula so that you all would see it. That's just a joke to finish off. But I just want to know if you guys have any questions. I know the scapula is not something you see very often. The clavicle is not something that you'll see all the time, but you know, it does occur. The most important thing to remember is if there's significant swelling, significant pain, especially on abduction, adduction, extension, and flexion, you need to start getting worried about the scapula as well. And if you remember to look at the scapula every time you're looking at those x-rays, you'll never miss it. But trust me, even me too now, I tend to look only at the shoulder and the clavicle. I forget about the others. But if you remember to look at it, you'll never go wrong. Okay, so there's no question. Everybody's happy.
Would you use years test for the humerus, fracture of the humerus?
I think you can, if I remember correctly. But you're asking the wrong person. I haven't done orthopedics since so long. This is the extent of my orthopedic knowledge. what I teach you guys. Okay, because I just need to be able to identify the. But you're right. I think the near, yeah, I think you can use it if I'm not mistaken. But you're asking me something that I have to go and check up on. Okay. Any other questions? All good. All right, no problem. All right, so I will see you guys next on the 18th. I am going for some sun and sand with my kids.